ready to go ahead and get started for the second? Wonderful. So, hello everyone. I think this session is much smaller here because, well, it's just more intimate, right? Because a lot of people were in this session to start. So we are gonna first go ahead and scan this because there'll be some questions. Hopefully it works. It worked kind of wonky the last time, but I think it worked pretty well overall. But go ahead and scan that. If you don't scan it right now, you will have an opportunity later, but you will participate in some polls here. And just let me preface this, I tried to in the last, so we're gonna talk about cardiovascular screening, but for those of you that are here, the slides will be available to you later. We will, if anyone reaches out to me, I'll be able to give it to you guys. I'll make sure that the leaders and the coordinators of GaPQC have it so that you can take this presentation back to your respective institutions and you can use this to train them. We'll have some things to give out to you guys to use to help you through this session to do kind of a hands-on portion. We are gonna skip through a number of the slides. The reason I didn't hide them all was because I wanted you to see the content that is in there so that if you have a session that you're doing if you're training your nurses or if you're training your providers, you may have a 2-3 hour session. You will have the time to go more through like the pathophysiology and go through all the Georgia data that we've gone through multiple times in this conference. So realize that when we skip through things, it's a lot of things that we've already covered. And then some of it we're not gonna delve into because again, we're really focusing on the screening and we wanna really get you guys in tune with the screening tool. So with that, I'm gonna hand it over to Dr. Schulman. And yeah, this is Dr. Bridgette Schulman. I'm sorry, she's at Northeast Georgia. Great thing about her is they have already instituted the cardiac screening, so we've gotten a lot of the help from her to get this started. And Dr. Aisabor, who is one of my third-year residents, who is doing this as a project at our institution. So with that, I am gonna be quiet and.
Yeah, so I'm glad we have a small, intimate group, like Dr. Byrd said. So we have a question. Go ahead and get your phones out. Start it off with a question. Oh, I might have gone the wrong way. Oh, I am going the wrong way. You're right. Down is up. Oh, okay. Sorry, down is up. Okay, I'm with you. All right, so I'm going to read a case study. We have a 24-year-old that did have a BMI of 38, identified as African American. She was a G2, P2, presents 10 days after an uncomplicated vaginal delivery with fatigue and just felt like she had just been coughing all night. So this persistent cough ever since she delivered. You can see her vital signs here were 110/80, heart rate's 110, respiration's 28. She did not have a fever, she was afebrile, and her oxygen saturation was 94. She got diagnosed with a respiratory infection and was prescribed antibiotics. And really, the provider just let her know, I think the fatigue is really that you just had a baby, you haven't slept, so just kind of attributed that fatigue to lack of sleep. So 1 week later, she presents again with the same symptoms, still really fatigued, still has this kind of persistent cough. They did switch her antibiotics and kind of just attributed this to a new onset asthma with this patient. 2 days later, the patient experienced cardiac arrest at home, and it actually wasn't, they tried resuscitative efforts, but those were unsuccessful. And it was actually only on the autopsy that they recognized this to be cardiomyopathy. So this is Dr. Shalon Irving, and I'm not sure if everyone in the room is familiar, but she worked for the CDC, very well educated, and unfortunately, even with education and knowledge about maternal health and statistics, did lose her life in 2017 and pregnancy and postpartum period. And so I won't read over these, but you can see we'll discuss causes. We're going to talk about signs and symptoms, talk about our risk factors, a CVD risk assessment, and then do some case studies. You saw this earlier. This is really just some definitions, so just recognizing there's a difference in pregnancy associated and pregnancy related, and we know that our maternal mortality ratio is based on those pregnancy related deaths per 100,000. And let's ask this question. Can you see it? Great. What is the most recent maternal mortality rate as of 2021? looks like 80% was correct, 32.9. So you can see here, again, I'm not going to spend too much time on these. You've seen these at different points, but you can see our maternal mortality rate is increasing. We know there's a significant disparity in health outcomes. And then one other question, what is the leading cause of pregnancy-related death in Georgia? So it's cardiac conditions. When you consider all of the cardiac conditions together, you guys have seen data earlier today from 2020 or 2018 to 2020, and then these are the Georgia stats, which I believe you've seen as well. This is just really to highlight the disparity. So our overall pregnancy mortality ratio is 35.6 per 100,000, but then if you look and dive into that, it's actually 58.7 if you isolate the non-Hispanic Black women compared to 22.4 for our non-Hispanic white women. We know that these are preventable. This was the data from 2019 to 2021. So I know we saw one earlier where mental health was the number one, but just looking at this most recent, cardiac conditions as a whole is number one. We see COVID come out this year, and then you can see the other top five. And then you've seen this as well in different ways, shapes, and forms today, but what's really obvious is we have to really pay attention, not just in pregnancy and in delivery, but 70% of our deaths in Georgia from 2019 to 2020 occurred after delivery in that postpartum period. So just really quick, we know just because there is a baby in your belly, your body goes through significant physiologic changes. We know that every system in your body adjusts in some way, but particularly our cardiovascular system, there's changes to our pulse, to the actual size and location, slight tilts and a little bit of enlargement, cardiac output, and our total blood volume. So we know overall there's a decrease in systemic vascular resistance. We know our heart rate increases a little bit, and we know that our blood volume increases pretty significantly to accommodate both mom's circulatory system and now the new needs of the uterus and the baby. And then we also know that there are changes in cardiac output at different trimesters, and then of course during labor, a little more significant, you can see in this graph. So another question. What is the most common presentation of cardiovascular disease during pregnancy and postpartum? I'm not going to say it out loud, but it's working so far. Yes, perfect. All right, so I'll let you take over, Dr. Byrd.
All right, so we know that shortness of breath is a common presentation, but again, it's the number one presenting sign in patients with heart failure and cardiomyopathy. But there are other things that also can lead to shortness of breath and patients can present with that can lead to heart failure, right? So cardiomyopathy, ischemic heart disease, congenital heart disease, pulmonary hypertension, valvular disease, all these things can potentially lead to heart failure. So don't just think cardiomyopathy, that's just one thing that can happen. All of these things can, and so with that, throughout the presentation, again, there's a lot of pathophysiology in these slides, but I'm not gonna go through all of those. I'm not here to teach you about every case of pulmonary artery hypertension. There are some slides here about it, but really I want you to focus on the icons that we put here. So when you have patients presenting with symptoms of palpitations and syncope, you might want to think about tachycardia and arrhythmias. Patients complaining of swelling or orthopnea, they can't sleep lying flat, they have to sleep on pillows, they have to sleep in the recliner. Think about fluid status and volume overload. Patients with headache, yes, of course, preeclampsia, but also think hypertension, elevated pressures. Chest pain, you want to think ischemia. Hypoxia, these patients might present with syncope, pleuritic chest pain, altered mental status. And then if patients have cough, shortness of breath, that could be, tachypnea be associated, but again, you're gonna start thinking of these things. So look throughout the presentation for these icons to think of what makes the perfect storm that can lead to heart failure. Because remember, over 50% of the cases of the patients that had deaths in the peripartum period were due to cardiomyopathy and heart failure, right? So you're really gonna look for those patients. And also all those other conditions with the severe cardiac conditions, those are mainly WHO class 3 and class 4. Those conditions are at high risk to end up in heart failure as well. So those patients can end up with that. And so these are some of those maternal cardiac conditions. Class 3 and WHO class 3 and class 4, a lot of things that you may or may not have seen before. So these are severe cardiac conditions. Of these, next question, which condition does the WHO advise against pregnancy? And you have a list of them that should pop up on your screen. Oh, there were only 4 votes, but it's a little slow.
It's letting the time run out first, I think, before.
Oh. That's what I get for trying to use something new, right? I'm trying to let you guys see the results, but
I see we have 14.
now we got, okay, so yes, for those of you who voted after the fact. But yeah, all of the above. And I put this here just to really highlight the fact that there are some conditions that are so severe that the patients are at significant risk of death. And so for those patients, WHO advises against pregnancy. So in these specific conditions, not all of the class 3 and class 4, but these should really raise a red flag if you hear a patient walk in your door and say, oh, I'm here for my new OB visit, like, yay. And then she tells you, oh, by the way, I have pulmonary artery hypertension that has, something else. So you really want to think about that. So I'm going to quickly go through these, and my only reason for going through these severe cardiac conditions is because we do know a large number of patients that present with cardiac acute symptoms and potentially are at highest risk for mortality will have these pre-existing conditions, although a large number will not have had any history of cardiovascular disease. But these patients we know are at significant risk, and you should be able to identify, like, oh no, I need to move much more swiftly in this patient than instead of letting her see the cardiologist in 2 months, this is a patient you might need to have seen much, much faster. And so that's one of the reasons why I want to highlight each one of these. So first off, cardiomyopathy and heart failure, which was the highest percentage of patients with deaths during the peripartum period. Again, heart failure, underlying cause of 9% in-hospital deaths among pregnancy-related hospitalizations, and that's just in the hospital deaths. I can tell you, I have personally had patients that, like Shalon Irving, died out in the field, out, with the ambulance that picked them up at the house, coded at the house. I've had actually 2 patients personally that coded outside of the hospital and were unable to be resuscitated, and with cardiomyopathy. So 9% of in-hospital deaths, but a large percentage out. And cardiomyopathy represents the largest group of women with heart failure. Again, I'm not going to go through all of the components of heart failure to tell you, but what you should remember about this slide, you see the different icons there: fluid status, ischemia, problems with heart rhythms and hypertension and shortness of breath. All of these things factor in to heart failure and cardiomyopathy. And remember, peripartum cardiomyopathy, again, can be associated with severe heart failure, cardiogenic shock, arrhythmias. So again, a lot of these things, thinking about arrhythmias, hypertension, those things can lead to peripartum cardiomyopathy and subsequently can lead to death if we don't catch it early enough. So again, heart failure in pregnancy. And remember too, patients with heart failure or cardiomyopathy in a previous pregnancy are at high risk to have it again. So because they have a history in the past, they have a high risk. But also, if you have a patient that had cardiomyopathy and heart failure in a previous pregnancy and her ejection fraction has not recovered, so she shows up in this pregnancy and her ejection fraction is 40 or 40, is less than what it is, she has a much higher significant chance of death. So you need to be very aware that if this patient, because some of your patients will recover. So some of your patients will come back, they had a history of cardiomyopathy, they come back, they have an ejection fraction of 50 to 55%, they're normal. Yes, they're still at increased risk of having a cardiac event, but not as high a risk of death as the others. If they come back and still have a reduced ejection fraction, you really need to make sure you are seeing that patient, evaluating that patient very quickly. And that's when you too need to evaluate whether or not they're below the threshold. If their ejection fraction is less than 30%, those are the ones that pregnancy is recommended against. So that's when you might have to talk about termination. But in everyone else, so if her ejection fraction is above 30, that patient will still be pregnant essentially, and then you need to be able to evaluate them quickly. Myocardial infarction. So again, we don't think about this much, but I've had 4 patients in the past with an MI or what's called PAMI or SCAD, so spontaneous coronary artery dissection, and then PAMI, pregnancy-associated myocardial infarction. Most commonly, these patients will end up coming in with dissection, and they can lead to quick heart failure and death. So I've had two patients that had pre-existing SCAD, and one of those 2 patients actually had emergent open heart surgery and repair 2 days postpartum. The other just got diagnosed then but didn't have it. And then I've had 2 others that did not have pre-existing coronary artery dissection. So just to show you, and all these patients were in their 30s. And so just to show you that you can have this to happen, most of the time they're going to complain of chest pain, but also hypertension. Those things are going to exacerbate it, and different arrhythmias or tachycardia is going to worsen it. So you really have to pay attention to those things. Again, I'm not going to go through all of these slides to take you through that, but pulmonary artery hypertension. So this is another condition that has a high mortality rate. And really the basis behind that has to do with mainly fluid status. So pulmonary artery hypertension have real difficulty managing fluid changes in pregnancy. And these patients can get into trouble very early in their pregnancy. So don't always think it's going to present, third trimester. These patients can actually present in the early second trimester if their pulmonary artery hypertension is not well managed. So, and I remember this because I did unfortunately have a 19-year-old patient with pulmonary artery hypertension when I was a resident who died. And so if you have a patient, and it'll happen, you'll have a patient to walk in and you get the history from her and she tells you, I have pulmonary artery hypertension. You're like, what? That is the patient that do not pass go, do not collect $200. You need to, if she's symptomatic at all, you probably need to put her in the hospital, maybe obs her and triage and get her seen by cardiology immediately. And if you need to do any further workup, that may need to happen, but this is not the patient that you wait around until, they have an opening in cardiology to get them there. Again, you see all the things that come into place here that can potentially lead to heart failure and death in these patients. So again, I'm just going through these to make sure that you know these diagnoses, so you know that when you hear these, they should make your bells and whistles go off. So patients with aortopathies, and those are not going to present and say I have an aortopathy. They'll have Marfan's or vascular Ehlers-Danlos, bicuspid aortic valve, Turner's, Loeys-Dietz, familiar thoracic aortopathies. So these patients, the main thing you want to know with them, they're not necessarily going to come in symptomatic because they don't really have symptoms, but you need to evaluate whether or not they have an aortic aneurysm or an aortic dilation, right? So they may not be symptomatic, but you need to know if they have a dilated aorta because, again, these patients are at risk for rupture, which can be sudden onset and catastrophic. So really, you just need to find out if they have an aortic dilation. That's going to be the mainstay of their risk for acute cardiac events. Valvular disorders. This is another one that I don't think people pay much attention to, but again, in knowing, being an OBGYN, we all talk to each other, right? We have friends in different cities and different states, and we talk to each other. We know about cases like, we had a maternal death at our hospital today, and we know, what she had. Unfortunately, I think a lot of these conditions get overlooked and they get sent to cardiology like, okay, they'll take care of it. These are some that, again, if you hear this, your hair should be standing on end, right? So you should be, all bells and whistles going off. But patients with stenotic lesions, so aortic stenosis and mitral stenosis, again, not going to go through all this now. even if it's been repaired, you need to know how long ago it was repaired, because these valves have an expiration date on them. And I have a good friend from medical school who's an interventional cardiologist, and she told me, she said they have not only do they have an expiration date, she's like, it's almost to the day you put it in that they don't last beyond that. So really and truly, she said, you know, depending on what kind of valve they have, usually they last 10 to 15 years, but you really cannot risk them going beyond that point in time. And she even went so far as to say, even if the patient is asymptomatic, if they are beyond the expiration date on when that valve should have been replaced, chances are, if you really probe them, she said, I bet you they're not asymptomatic. I bet you if you ask them enough questions, they are truly symptomatic. And many of those patients would actually require valve replacement during pregnancy. So don't always think, and again, unfortunately, I've had a patient succumb, aortic stenosis, got put off. Even the cardiologist said that they wouldn't replace it during pregnancy because they said she was asymptomatic, got into her second trimester, and unfortunately, she died as well. So again, with delay in diagnosis, misdiagnosis, and then actually not getting an intervention. And so realize too, but stenotic lesion, if you remember anything, remember the S for stenotic lesion is severe. So those are the ones you need to be, and S for scared too, right? So you should be scared, right? So be very scared if somebody comes in with aortic stenosis. Again, and now I've had two patients, with one in residency and one since I've been attending, and both passed away, unfortunately, with aortic stenosis. And again, I wish I had known these things sooner. Mitral stenosis tends to be a little bit better tolerated, so not as likely to have a maternal death, but they still are at 30% risk of an event. But you should still be aware. Again, not going to go through all these, but again, see the icons all over floating around, can still lead to cardiogenic shock and even death. And so the regurgitant lesions, though, those are usually pretty well tolerated. So aortic regurg, tricuspid regurg, mitral regurg, those are usually very well tolerated. So those are not so much ominous, but the stenotic lesions, again, S for scared. And then these two I'm not going to go into, but congenital heart disease and arrhythmias, because we have great pediatric surgeons now who are repairing hearts in these young babies and neonates, we are seeing these people grow up into adulthood and then become pregnant. So you will have patients that come to you with a repaired congenital heart defect. If you don't know what it is, though, still be very, very wary of what it could be, because if this patient comes in and starts to have symptoms, you don't know that this is something that is still existing and needs to be evaluated and treated, but those patients are at significant risk as well. And people with arrhythmias, things like complete heart block, things like that you don't really think about, could be at significant risk with the stress of labor and the stress of pregnancy itself. I'm going to let Dr. Schulman go through these, and then we'll get to the cases.
So yes, we know about those that come with cardiac conditions, but we also know that there are risk factors with patients that may not have known cardiac conditions, but might have an increased risk later on down the line. And one of those is preeclampsia. We've seen that a history of preeclampsia does increase your risk of cardiovascular disease in the future. And in fact, you have double the risk of having a heart attack or stroke. And if you have the diagnosis before 34 weeks, you're actually 4 times more likely to develop cardiovascular disease. So patients with preeclampsia that had severe features or have had preeclampsia more than one pregnancy do have an increased risk as well compared to those who had mild or moderate or did not have preeclampsia. And in fact, we know that in 2011, the American Heart Association added preeclampsia, gestational diabetes, and elevated blood pressures in pregnancy as a risk factor for developing cardiovascular disease. And so if we know this and we know that this is a leading cause of death, how is this still happening, and why does it continue to be on that top of the reasons that our moms are dying in Georgia? And part of it is a delay in inadequate response to things that are there, the clinical signs and symptoms that are there, but are maybe being just considered kind of part of normal pregnancy. Ineffective or inappropriate treatment, a misdiagnosis, or a failure to refer to the appropriate specialty or consult. And so what can screening do? So if we do screen, we're going to increase the patients' and providers' awareness. So providing a differential diagnosis. So they are thinking about cardiovascular disease and not just saying, oh yeah, you're shortness of breath, you got twins in your belly and you're 32 weeks. Of course you are. Or yeah, you're tired because you just had a baby and you're not sleeping. It gives us that differential to say, hey, is this normal pregnancy stuff, or could this be with enough of the risk factors or the, we'll talk about that. Also, we identify patients that are increased risk. And so when we identify them, when we recognize them, then what are we going to do? Well, hopefully we'll respond. So we're going to get them that referral. We're going to get them where they need, or at least get them worked up more, get a deeper look at what's going on with them, and then possibly get them a referral. And then it's also an opportunity to modify those risk factors that are modifiable. So maybe it's that we recognize these risks and we can start getting things like weight or blood pressure control, diabetes control, things like that. So recognizing that they have these risk factors does allow us opportunity to not only get them to the right place at the right time, but also possibly modify some of those risk factors. And so hopefully, if you take nothing else home, I hope that you understand before you leave this, and we're going to apply some different things to case scenarios, but that a pregnant mom might present with cardiovascular disease for the first time in pregnancy. So we talked about the ones that we know might have it, but this might also be the first time she presents with signs and symptoms of cardiovascular disease. Usually these symptoms are going to get, they could get worse about between 24 and 28 weeks. That's a big time that we might see changes, and then also during that postpartum period. And then we should always take abnormal vital signs or risk factors seriously in our pregnant moms. Don't fall into that trap of saying, well, yeah, it's because you're pregnant or because you just delivered. And then the biggest one is screening all women that are pregnant and up to 365 days postpartum can help identify those that are at risk. So with that, we have another question, and I'll pass it back over.
All right, so which biomarker has been shown to aid in the diagnosis of heart failure? What, a few more people answer? All right, so BNP. So BNP is a neurohormone secreted by the ventricles in response to volume expansion and pressure overload. And so it's really useful in pregnancy to help with the diagnosis of heart failure. With dilated cardiomyopathy, higher BNP predicts cardiovascular outcomes. It helps with evaluating shortness of breath and left ventricular function. And so again, looking at BNP, and again, we're lining up all these things, right? So patients with previous cardiovascular conditions, looking at risk factors, but we're also looking at what things can we use, so other than symptoms, what things can we use to help objectively screen these patients for heart failure, again, because these are the patients most at risk of having a maternal mortality or maternal death, right? I'm not gonna go in through normal levels, but what BNP level is diagnostic of heart failure? Let's see if you know this. So 100, and let's see. So good. So I think you guys are probably using the other here, so that's a good sign though. So what is suggestive of heart failure is a BNP of greater than 50 but less than 100, but diagnostic is greater than or equal to 100. And then there is also the NT-proBNP. So I see that some of you guys answered 450, but NT-proBNP is also used in some settings in some hospitals, and basically greater than 450 but less than 900 is suggestive, and then over 900 for most intents purposes is diagnostic of heart failure. Your cardiologist may differ in these by a little bit, 50 or 100, but most of them will agree with these numbers in general, but they will use one of these at your hospital to aid in the diagnosis of heart failure. I'm not going to go through all these. We talked about some of this, but you should know that when your patient is postpartum, by 2 weeks, her signs and symptoms should be getting better. So if a patient is getting worse 2 weeks postpartum, you need to be really concerned. We talked about, presenting for the first time. These are just some things too that you need to think about when the patient comes in with shortness of breath, new onset coughing or wheezing, difficulty performing normal activities. Another big one is if a patient has to stop repeatedly to breathe in between sentences while she's talking, that's a red flag. If she's got to stop just, and she didn't run in there, if she's just, walking around and she's short of breath between sentences, you need to consider putting her in triage and evaluating her. And again, lying flat, we're going to go through all these. Again, you guys know about the peach cards. These are available in Spanish as well now. They're available as a refrigerator magnet and as a card, so you can do that. You guys should have the paper algorithms one. So you have the badge buddies, the paper algorithm with the laminated cards, yes, and you guys should all have dry erase markers, right? So we're going to go through some cases to help you practice using this. So again, just so you know, California did all this with the toolkit, the cardiovascular toolkit, and they applied this algorithm to 64 of the deaths that they had during this time, and 88% of them would have been identified if they had used the screening algorithm. And then the detection actually increased to 90% when they restricted patients who were symptomatic. So if you just use it on patients that were symptomatic, it's going to catch most of those. But they used it on patients that weren't symptomatic as well and would have identified 88%. So the who, the when, the how. ACOG has also endorsed the use of this screening tool. So why is screening indicated? And ACOG said who should be screened is all women should be assessed when they should be assessed antepartum and in the postpartum period, and then how using the CMQCC screening tool, which you guys have there in front of you. So what you have is a couple of versions. You have one, so this is the same thing. We just changed the infographic to make it look a little bit nicer. We put it on a badge buddy front and back. You also have the posters that are there that you can put anywhere. And then what's on that sheet, that laminated sheet, is also the same thing in written form so that you can do the scoring yourself. What you should know that it's twofold, right? So there are two parts. We call this the maternal cardiac warning. If you think warning, you need to take cover right now. Do not, again, don't let this lady go home. She needs to be evaluated right away. So these are red flag symptoms. So shortness of breath at rest, severe orthopnea, patient sleeping in a recliner because she can't lay flat, greater than 4 pillows, greater than or equal to 4 pillows, heart rate greater than 120, systolic blood pressure 160 or greater, respiratory rate 30 or greater, and then O2 stat of 94% or less. If they have any of these, any patient that's pregnant or in the postpartum period, send them for prompt evaluation. This patient does not go home. It is go to triage right now to be evaluated. If they're in triage, you need to go ahead and go to the next step, which we'll talk about what that is. And then plus consultation with MFM and primary care cardiology. If they have a personal history of cardiovascular disease, so those WHO class 3 or 4 people, and they don't have any of these red flag symptoms. So if they don't have those, they still need consultations with MFM and cardiology, and I would just advise you to decide when that needs to happen. It still may need to happen soon, within a week, a couple of days. It may need to happen that day if you really need to find out if she's at risk for something significant happening very soon. But again, it's not as acute as the people who have the red flag symptoms themselves. So this is basically for everybody else. Most of the people that you screen are going to fall into this category of the maternal cardiac watch, right? So most of the people are not going to have severe symptoms, right? Not red flag symptoms. Most of the people are going to have something in this range, right? So the way to go through this, I'm going to walk you through it. There's a symptom, vital signs, risk factors. So using those, basically, let me go back. So we're going to walk you through. So there's the symptoms, vital signs, and risk factors. Those 3 altogether. If you have one in each category, so if you have at least 1 symptom, 1 vital sign, 1 risk factor, you screen positive, you automatically go to the next step. Or if you have any combination of 4 in any of those 3 categories. So if she has 3 symptoms and 1 vital sign and no risk factors, that's 4. She screens positive, go to the next step. Okay? So either 1 in each category of those 3, or any combination of 4. Over to the right, the physical exam is completely separate. So if they have those 2 abnormal physical exam findings, those automatically also go to screening. Okay? I'm going to walk you through that. So here's another case, and this is where you can use that paper, the laminated screening tool that you have. Try using that on these next couple of patients and the cases that we have. 25-year-old obese African-American G2P2 presents 10 days postpartum vaginal delivery with fatigue and persistent cough. Since delivery, There are her vital signs. You can see, looks like heart rate is 110, respiratory rate 28, afebrile, O2 sat 94%. She gets screened using the CMQCC tool and is sent to the hospital for evaluation. So this is showing you here, why did she get sent there? It's because she had an O2 sat of 94%, right? So she automatically has symptoms and she has a oxygen saturation of 94%. She goes to the hospital to be evaluated. You don't let her go home and see what's going on, and you don't give her Lasix and tell her to come back later. No, she goes directly to the hospital. So that's how you use this screening tool. So severe symptoms, they automatically get evaluated and get the next step. At the hospital, she gets a chest x-ray, EKG, NT-proBNP. Chest x-ray reveals mild pulmonary edema. EKG is significant for sinus tach. NT-proBNP is 750, and so an echo is ordered because that is elevated, right, and suggestive of heart failure. Echo shows an EF of 45 to 49%, which is cardiomyopathy, right? So admitted to the CCU for peripartum cardiomyopathy, remains in the hospital for 4 days until she's discharged home, followed up by cardiology with Q3 month echoes, brings her baby to her 1 year visit when the baby's a year old. And I put this picture here, that's my little sister, and she's fine, she didn't have anything happen, but I put these pictures in also to personalize the story, right? We had Shalon Irving before, most of us know about her, but we didn't know her, right? So when you present this information to people and you're training them, it may make sense to make this be personal, right? So, and I can tell you, my sister postpartum called me, and she's a PhD, she's a smart girl, she called me multiple times, like FaceTime, and she's like, I'm swollen and and giving me something, do I need to go in? And I'm like asking her questions, but I could see the terror in her face because she is very vividly aware of what's happening across the country and the maternal mortality rates, and specifically the Black maternal mortality rate. So it just brings it home, when you see, and I was from, she's in Houston, I'm here, I really was a little scared as well. I don't want to tell my sister that she shouldn't go in and she ends up having something happen, right? So really just make this personal for yourself. So some key points: red flag symptoms require immediate attention, and patients that are symptomatic but without red flags should be screened using the maternal cardiac watch. So then you have another patient, 25-year-old obese female. So again, tweaking the same case again, presents to the ED 10 days later, same symptoms. This time, O2 sat is 95%, so a little different. She gets diagnosed with new onset asthma, is prescribed albuterol. 1 week later, she comes back with continued symptoms and complains that the inhaler is not working. The nurse in the office applies, because she came to this conference, applies the CMQCC screening tool, and these are the vital signs. So again, very much similar, but now she has asthma that's unresponsive to therapy, right? And that's one of those red flags. So the patient, or one of the risk factors, and so, or symptoms. That patient screens positive. And if you go here, so she had asthma unresponsive to therapy, heart rate 110 or greater, respiratory rate above 24, O2 sat. So she actually screened positive 2 ways. She has at least 1 in each category, and she scored more than 4, right? So then she and a BMI of that. So she goes to the next step, right? So again, remember, 1 vital sign, 1 symptom, 1 risk factor. That is a screen positive, or any combination in the 3 categories that add up to 4 or more. Patient is seen in the hospital. She gets a chest x-ray, EKG, BNP. BNP is 220, so that is heart failure, right, because it's a BNP. Echo shows an EF of 40 to 45%. She's admitted to the CCU, treated for cardiomyopathy, stays for 8 days, discharged home, followed by cardiology, Q3 months, brings the baby to her 1 year visit. And this is Dr. Winley, who is an OBGyn. That is my patient, but also same with Dr. Winley. I took care of her, but I can tell you that she was, at multiple times, even though she's an OBGyn, voiced her being terrified of ending up, with a cardiomyopathy and other things, especially with twins, and she was like, Byrd, she's asking me all the time, should I get this? And even postpartum, ended up getting a BNP and echo. Because her BNP was mildly elevated. She said she was okay with me sharing that with you guys. So I'm not violating HIPAA. She told me it was fine. Because I had to ask her to put her picture in this anyway. Okay, new onset asthma in adults is rare, so don't go diagnosing asthma in 30-year-olds. It can happen, but it's just not that common. So if she just had a baby, you need to be looking for something related to the heart. And don't be fooled. You can also improve CHF with a bronchodilator, with bronchodilators like albuterol. in the short term. So don't just think, oh, she got better, so it has to be asthma. Make sure you're ruling other things out first. All right, so last tweak on the same case, and then we'll get to some more different cases and we'll be done. 25-year-old obese, same thing, presents 10 days after uncomplicated delivery, persistent cough and fatigue. Now this one's O2 status, still 95%, gets diagnosed with a respiratory infection, is prescribed an antibiotic. Fatigue is attributed to lack of sleep. So this one has a respiratory infection, we think, huh? Afebrile though, okay. 1 week later, presents to the ED with continued symptoms. The PA also heard about this because you guys brought him a badge buddy and they saw this, and identifies bibasilar crackles on inhalation, and then gets the MFM evaluates the patient, gets an EKG, echo, BNP, and consults cardiology. Lab studies consistent with cardiomyopathy, same thing, discharged home after a 2-week course. And again, this is one of my residents, Dr. Jones, who, again, if you make this personal, these are people that you see all the time. Could it be them? Again, wasn't her presentation, but again, you have to make it personal to know that these people are all around you, and potentially you can save lives just by implementing the screening tool. All right, and so for this one, again, this is abnormal findings. So this is all in category by itself. If you have a patient with a loud murmur or bibasilar crackles, they automatically go to consultation, and likely that consultation should happen in the hospital. So it could be in triage and evaluated, and then potentially EKG, BNP, all right? Loud murmur is defined as audible with the stethoscope lightly touching the chest, and then bibasilar crackles are usually found on inspiration. So again, these symptoms should be improving in the postpartum period, so it's a warning sign if they're not. Multiple visits to the emergency department should raise your suspicion. If a patient tells you, I've been to the emergency room multiple times for shortness of breath or these vague symptoms, especially postpartum. Bilateral crackles on lung exam are most likely associated with congestive heart failure, and then new onset cough or postpartum dyspnea is concerning for cardiovascular disease. And again, pneumonia is uncommon in immunocompetent patients. Adults is rare, right? So yes, COVID is there, yes, influenza, things like that, but if they test negative for those things, just coming in with a community-acquired pneumonia is gonna be rare in adults. If a patient's presentation is inconsistent with infection, you should consider a cardiac workup. So when they screen positive or at risk, what should you do next? And that's when on the screening tool you move to this. So all of them, the next step is get an EKG and BNP. Does it mean that you're gonna order a lot more EKGs and BNPs? Yes. And I think that our colleagues at MCG that have already started screening have already noticed an uptick in the EKGs and BNPs they order, but it's a blood test. If it's something that potentially can rule out or rule in heart failure or cardiomyopathy, is it worth it? Yes. So you do have to know that you're gonna see more of these, but also aside from that, if you need to then order other things like echoes and chest x-rays, you are gonna have more echoes that need to be ordered. You probably need to talk to cardiology to say, you're not gonna end up with hundreds of these necessarily, but as Bridgette said before, their screen positive rate is about 4%. That's about what you expect to see, somewhere along the lines of definitely less than 10%. So you're gonna see some, and you're gonna have an uptick in those. What you're gonna have to work on is how quickly you can get those echoes done. And so you might need to do other things. So EKG and BNP is the next step if they screen positive. And then whether or not you need to order these other things depend on if you think she's got a PE, if you think she's got thyroid storm or something else going on. And then again, imaging-wise, chest x-rays, they actually don't offer that much information. So most of the time getting them is not of any use. But then echo if your BNP or pro-BNP is positive. And then Dopplers if you think she may have a PE or if your ABG is abnormal, you're gonna order those other things. And then cardiology consult as indicated. So now we're just gonna skip through. So this is what you should have there where you're using this. This is what Northeast Georgia used in their hospital to start the screening process. This is what we are gonna be using to screen our patients in a paper format until we can get it into our EHR and to get our providers and nurses familiar with it. Know that it's the same thing that's on your badges, it's just in a paper form so you can document it. And same thing that's on here. So now I'm going to skip this and then remember you can screen anywhere. Triage, OBGyn, emergency department, but the outpatient office is also going to be important at some point too. So now we're going to move to the cases. All right. And Dr. Aisabor is going to. No, it's the same QR code. All right. So you guys should, I don't know if you guys still have it on your phones, the Options should be on there. We're just gonna walk you through these cases, and then once we walk through, we'll let you guys ask us any questions.
So the first case we have here is a 42-year-old G2, P2, African-American female, post-op day 1 from a repeat C-section, complicated by postpartum hemorrhage. She now has complaints of lightheadedness and palpitations. Her vital signs are there. Her blood pressure is 98/65, heart rate's elevated at 120, respiration's 14, temperature is 98.9, and O2 sats are 98%. So what's the next best step for this patient? Okay. So the answer choice here was CBC. So in some of these, we have mixed in just normal routine postpartum issues. So this patient would have postpartum anemia. She did have a postpartum hemorrhage. Tachycardia could be related to the anemia as well, and she's hypotensive. So the first line for that would be to get a CBC to evaluate the hemoglobin.
And so, just to clarify, that patient did
I
screen.
didn't know, just so you know, I was gonna pick CDC.
Right, right.
So,
we
find out.
We threw a couple of these in here just because we don't want you to throw the baby out with the bathwater. I guess it's not the greatest conflict to say that, but you still don't throw away all the things that you know, right? She's post-op from a C-section. She had a postpartum hemorrhage. You still need to know if she's got anemia, needs to be transfused. So don't let this all go out the window. And technically, she did screen positive she had enough checks to screen positive. But go to that first. If her hemoglobin's 6, transfuse her. But then it doesn't mean that later, if she still screens positive after you fix that, then she might warrant an EKG and BNP. But right off the bat, don't just do it all the time. Still go with your gut with patients that have a reason. But then if you fix other things, then still be looking for, and she still has symptoms, then move on to do it.
I get that, but she still met 4 of the criteria. Yeah.
Right, but if you, so you don't necessarily have to do it right away. That's my point.
Gotcha.
So you don't just say, oh, she screens positive and I need to go ahead and do it. If she has an acute issue that you need to address, and we'll have a few others thrown in here like that, address that first. But then if after you fix that or you realize that's not really the case, then if you get back that her hemoglobin's 12, and she still has this, then yeah, you need to do an EKG and BNP, okay? But if it's 7, you don't need to do an EKG and BNP first, you need to transfuse her, right? So yeah.
And some of that comes in the timing of the screen and the place of the screen. So if you're, it's just, just to her point, maybe you're going to address the immediate issues and then screen on day 2 postpartum because you know that she had X, Y, and Z. So.
Very good points there. So our next case, this is a 43-year-old African-American female, G1, P1 at 6 weeks postpartum visit, having complaints of congestion, shortness of breath, sore throat, subjective fevers and chills. Blood pressure is 149/88, heart rate is 117, and temp is 101.3. What's the next best step? Great. Yes. So this patient's presenting with upper respiratory symptoms, so likely she has an upper respiratory infection, and the first thing to do would be an upper respiratory panel, even though she has some of these vital signs that could screen positive on our assessment, but we're addressing the acute issue first. And this is pretty likely upper respiratory infection. Next case, a 34-year-old G3 P2, postpartum day 0, status post-spontaneous vaginal delivery, now complaining of chest pain and dyspnea 30 minutes after her delivery. Her blood pressure is normotensive, heart rate's 115, temp is 99, O2 sats are 98%. On her lung exam, you hear bilateral crackles. What is the next step here? Chest x-ray is a good answer, but with the physical exam showing bilateral crackles, it would be good to evaluate for cardiac dysfunction or heart failure. So EKG and BNP was the correct answer in this situation. We're concerned about peripartum cardiomyopathy.
And
Would you
remember,
not take, so I picked both, which clearly didn't allow. Yeah, but that's fine. But don't you think we would look that? We would look.
you would, but again, how much does your chest x-ray lag behind anyway? And you don't want to miss a heart failure, right? So if you know you have the crackles, so again, if you know you're gonna order EKG and BNP, because that's the next step on there,
Do it.
why are you waiting, right? So the imaging is kind of secondary to the lab. But crackles are so much so associated with heart failure that they really want you to have a higher suspicion to rule it out before you just say, let me just get a chest x-ray because you're gonna see pulmonary edema.
I
And
think
that's it.
that goes back to just the basic skill set of like, are we able to distinguish crackles, wrong by red, like,
Right.
you know what I mean? Like,
Right.
people need to remember what that sounds like.
Well, and you don't want to get back, if you get a chest x-ray and it shows pulmonary edema, right, because its crackles could be pulmonary edema, and you stop there, does she not have heart failure?
Right.
You haven't necessarily ruled it out just because she has a positive chest x-ray. So I think that's part of the dilemma too, is that having a positive chest x-ray, a lot of people might stop there and say, oh, she just got preeclampsia with that, and not know that and miss the heart failure, right?
Yeah, excuse you.
All right. Next question, or next scenario here is 32-year-old G1 P0 at 38 weeks with a past medical history of asthma presenting to your OBED or labor and delivery triage with cold-like symptoms for the past 3 days. She reports worsening shortness of breath and wheezing, not relieved with her albuterol inhaler. What's the next best step? So for this situation, it seems like she's having an asthma exacerbation, so it would be a nebulizer treatment, but this could also be one of those situations where you have to evaluate for cardiac issue as well. But for an acute situation with asthma exacerbation, we would do a nebulizer treatment, and then the next case kind of piggybacks off of this one. So this is the same patient coming back a week later, now complaining that her breathing treatments at home are not working. She's normotensive, her heart rate's 126, respiration is 30, temp is normal, O2 sats are 96. What's the next step? Okay, so now we would do the EKG and BNP to evaluate cardiac function because it's asthma that is not responsive to treatment that we would normally do. A 25-year-old G2 P1001 at 12 weeks gestation with a history of congenital heart defect presents with a blood pressure of 130 over 80 and a resting heart rate of 120. What's the next best step? Sorry, was somebody still trying to answer? It looks like we have a spread here, but it would be prompt eval in the hospital just to get her more evaluation because you don't know what kind of congenital heart defect this is, and her resting heart rate is elevated above 120. That's a red flag sign there.
So this is where, you know, it gets a little tricky too, but again, remember I told you, those WHO class 3 and class 4, be very careful of those patients, right? She has a congenital heart defect, but you don't really know what it is or what it was, but her heart rate's 120. Like, why does she have a resting heart rate of 120 and she tells you she has this? We're not saying she has to be admitted, but you already know she needs a cardiology referral, but do you send her as an outpatient with a 120? She's better off if you probably get her in triage and at least have them see her. It doesn't mean you need an EKG and BNP right now, but she probably needs to go to the hospital to be evaluated and have cardiology see her so you can get more history about this congenital heart defect and if they need to order one, you know, but she's not somebody that you just say, you'll follow up in a couple weeks. If she truly had a heart defect, then you probably need to evaluate her with that high heart rate.
And I wonder though, if you don't have an OBED and she shows up in the ED, she's gonna sit there, they're gonna look at that, she's 12 weeks and maybe explain it away, and then they're gonna send her for a cardiology referral.
Is that where you guys send your patients when, like,
Correct.
you don't have a OB triage either?
Correct, we do, but it's 20 weeks or greater.
Ooh.
Yeah, so that's why it's cardiology referral would be a better.
So, well, and that's where this is going to tease out a lot of things for your institution, right? And that's what the dilemma that you run into is that because you guys see patients in different settings and have a different flow,
Sure.
it depends. I mean, honestly, your provider may decide you can directly observe her, right? You could just put her in for a direct observation and get cardiology to see her. I've done that. I've said I know it's going to take hours for cardiology to see her and said I'm just going to do an observation of 23-hour obs and put her in and just put the consult in. So in order to save her that from potentially getting this, or, you know, I'm sure your providers can also see the patients in the ED. I know they don't want you, but you could, you know, send them with something and say, hey, you know, talk to the ED people. But without that, I probably would observe myself if I knew she had the potential to get sent home. I wouldn't send her to the ER just with a blanket like go there. I would make sure that she's going to be seen. So if that was going to happen, I'd probably opt there and have cards to see her.
Okay. Our next case, a 35-year-old G4P2012 with a history of Marfan's disease, presenting to clinic at 8 weeks for her IPV. Vital signs are stable and she's currently asymptomatic. What is the best next step? Okay. This patient has Marfan's disease. However, she is currently asymptomatic, but it would still be good to get a baseline echo because with pregnancy, you can have worsening of aortic root dilation. It's good to get a baseline just to see what it's currently at. And with pregnancy, there's a risk of aortic dissection with dilated aortic roots. So it's good to get a baseline just to see where to start and then go from there.
And let me just qualify this one. The first one, cardiology in 1 to 2 months is just too long to wait. If you don't know whether she has an aortic root dilation, because some of them, if they're large enough, require surgery. Some surgery is indicated even while she's pregnant. Prompt evaluation in the hospital. You know, Marfan's is a little bit different in that they are aortopathy. So the reason you just want to get them evaluated and know quickly is if she is being asymptomatic, then being at risk, needing surgery is her main issue. You really want to find out if she needs surgery right now, right? And, but you're not thinking that something's going to happen. Because Marfan's tend to be, she's not really going to have symptoms per se. She's at risk for dissection. So those are just, if they're, at some point it's going to rupture and that or dissect and she's going to die quickly. But they don't necessarily have symptoms like all the others because they don't, it doesn't really happen in that way for them. Really, they just have, you know, hypertension, tachycardia can cause that to rupture. So they don't really have a lot of symptoms before, so you really just need to find out whether or not she has an aortic aneurysm or aortic dilation. And waiting 1 to 2 months is just too long. You can't not know for that long period of time. And that's one thing that we realized here, and I see you guys in TV shaking your head. Like, one thing that we're realizing too, and the reason I put a lot of these cardiac diseases in here is because again, knowing the cases that we have had throughout the state and knowing the cases I know, in the patients with known cardiovascular disease, this is where we have dropped the ball in kicking the can down the road with these patients with known cardiac diseases, saying, oh, well, she'll get in to see them, and oh, they said whatever. We run into cardiologists that are not well versed in maternal physiology. We run into cardiothoracic surgeons who are not wanting to do things because they don't know. So sometimes you have to be the impetus to say, no, she needs to get in sooner, like now, so that we can find out if something happens. And you guys had a Marfan's, well, I mean, I won't say you guys, but you know of a Marfan's case
Yeah,
there.
and I just think that just to her point, you know, it was a large aortic root dilation, and we kind of like, oh, she's gonna make it through pregnancy, and then she did, and then postpartum, you're worried about that postpartum time, and then she did, and then literally died like in the ICU eating breakfast on the monitor, so like, and just dissected. So it's tricky.
A 30-year-old African-American female at 18 weeks with past medical history of peripartum cardiomyopathy, here for new OB visit. While taking her history, you notice that she stops to breathe in the middle of her sentences. Blood pressure is normal and urine is negative. What's the next step? All right, the correct answer here is prompt evaluation in the hospital. So she's having conversational dyspnea, and she has this history of peripartum cardiomyopathy. She's pretty early on in her second trimester, so she would need to be evaluated pretty quickly in the hospital. And then obviously refer out from there. I think that's, one more. 35-year-old African-American female, G4P4 at 12 weeks with a history of aortic stenosis, status post biological valve replacement. 15 years ago, she reports conversational shortness of breath. She's normotensive with a resting heart rate of 115, O2 sat 95%. What's the best next step? Okay, so also another patient that needs to be promptly evaluated in the hospital, and then also consult MFM and CT surgery. CT surgery needs to be consulted to replace her valve. So usually the time frame for those are about 5 to 10 years, and she's over that, so it's expired at 15 years. She's also having elevated heart rate, and then her O2 sat is less than 96%. And this can worsen pretty quickly in pregnancy. So it's good to get her evaluated pretty quickly there. All right, that's our last case.
So that is the end of our presentation. So we wanted to open it up to any questions that you guys